with Kate, also known as Caitlin, but usually called Kate. We're going to give you some patient and GP perspectives on what trauma-informed care is and why it matters. And hopefully this will leave you all kind of feeling that a lot of what you've been doing already is trauma-informed care. And there are some small but profound changes that you can take away that will make your care even more trauma-informed and make you feel more kind of resilient as a result. So I'm Jonathon Tomlinson. I'm a GP at the Lawson practice in Hackney. And I'd like to introduce, or let Kate introduce herself as well. I'm going to stop screen sharing so you can see us.
Yes, hi, I'm Kate. I don't know if you can see me.
We can.
You can. Okay, great. I live at the Amy Winehouse Foundation, where I have lived now for 2 years, and I have been through various institutions, supported housing and rehabs and detox, battling a ketamine and crack and heroin addiction. And the foundation has given me a safe and supported and loving place where I am now able to go to university, volunteer at Brook, sex education charity, as well as help Dr. Tomlinson on the importance of trauma-informed care. But before we start, I would just like to recognise that I appreciate that I am a white young person, and sitting in the Lawson practice, I know that I am not representative of all patients by no means, and this foundation has given me a lot more support than most people. However, it has allowed me to get to the point where I'm able to speak to you today and hopefully give you some insight into how trauma functions for me and perhaps other people, and kind of add the human back into the textbook. Yeah. That's
brilliant. Thank you so much, Kate. Yeah, I'd just like to back Kate up there and say, I've realized that a background of trauma during early childhood and development and within intimate personal relationships is a factor in maybe 60, 70, or even 80% of my consultations. And the more I'm attuned to it, the more I'm aware of just how prevalent it is. And so many of the patients that I look after are maybe in their 30s, 40s, 50s, or even older. And I'd like to recognize just how amazing and brilliant it is that the Amy Winehouse Foundation is supporting women at such a young and important age. Most of them are in their early 20s. And I just wish that this kind of thing had been available for my older patients at that time in their lives. So it is a wonderful place. We're going to go through just a handful of slides together and then bounce ideas off one another to help you get an understanding of what we mean by trauma and trauma-informed care. So I'll share the screen again, and then we'll go through them. So Dr. Gabor Mate, who writes and speaks very beautifully on this subject, makes the really important point that trauma isn't what happened to you, but it's what happens inside you as a result of what happened to you. So when we're talking about trauma, we're not talking about your childhood or abuse or neglect or an accident or an event. Those things can be traumatic. But when we see patients, those events have usually passed, not always, sometimes they're ongoing, but often what you're seeing is somebody who's carrying around inside them as physiological, psychological, or behavioral issues as a result of what happened to them in the past. And because trauma, which is often referred to as PTSD, or when the trauma is in childhood or is prolonged or is at a lower and more insidious level, is sometimes referred to as complex PTSD. And most of us will know that PTSD involves things like flashbacks or reliving the event, or re-experiencing what happened. And I think that's really key as a kind of understanding of trauma. And trauma-informed care, just to clarify at the beginning, it's not therapy. So I'm not a trauma therapist, and patients don't get trauma therapy, even if what we experience together is therapeutic. And it's not going over or trying to find the details of what happened in the past, although often, and especially if patients feel safe and they trust you and they have time, they will tell you and they will talk about it. And trauma-informed care is not just for trauma specialists or even just for clinicians or GPs. It's for everybody in an organization, from the receptionists who see the kind of behavior and deal with people as they come in, to the secretaries who write letters detailing the problems and the histories that patients have, to the managers that help set up services in a way that's sensitive to this. And trauma-informed care is attuned to the presence of trauma. As I said, it's up to 80% of all the patients I see, and many of the staff I work with. It understands the ways in which trauma affects people, and it's underpinned by safety, trust, choice, collaboration, and empowerment. And whenever I teach, I always do this with a patient who can speak from first experience, and it's for everyone. Kate, do you want to add anything to this, or just say what it means for you?
Yeah, I just wanted to say that in my experience, the reaction that I got from traumatic events in my life was always considered as a badness. And this was never direct, because the traumas I was experiencing were so normalized in my life, and no one saw them as trauma or events. And it was always about my resulting behavior right in that moment, which people never explained to me was as a result of something. It was just who I was. And this badness inside of me was being reinforced by being told that my inability to concentrate, my rebellious attitude, or sleeping all the time, my anxiety or my social anxiety or my depression, my mood swings, wasn't because of these events. It was because I was chemically imbalanced, and I knew nothing about trauma. But the people that did know, the professionals, told me that that's just the way it was through labels and diagnosis. So yeah, I think that's just quite a interesting
So you felt sort of judged by your behavior, rather than sort of understood in terms of what had happened to you.
Absolutely. And I think there's such a pressure to look at the symptoms and what are the symptoms in front of me, and how can we kind of sort those out, because that's quite easy. We have medication for that. But often, if you don't sort the root, it's just going to stay the same. So I think it was always, and when stuff didn't change because the root hadn't been looked at, there was so much dismissal, because it was like, well, nothing's working, so we don't really know what to do now. And yeah, there was a lot of judgment for me not being able to change.
And how long did this continue until the idea of trauma began to be introduced in your kind of conversations with professionals?
All the way up. Since 14, I was put on antidepressants off and on, and every time I went back, the dose was increasing. And the first time that trauma was introduced was in rehab. But mainly since I got to the Amy Winehouse Foundation, when they saw drugs and all of this stuff as coping mechanisms for something that was a lot bigger, and it took for people to say what happened rather than what have you done, for me to realize that it wasn't just me, it was something that had happened to me, which I think is a really big thing to understand, that some things out of your control can create these reactions in you that you need to protect and kind of put on this facade, this armor, so that you can then face the world. And that armor is the thing that people see, and they don't look beyond it. And that is so frightening for the person that's going through it, because it's like no one understands this.
Thank you. Yeah, that's so clear. Thank you. Look, I think this leads us on to this quite nicely, Kate. This is a slide about something called the window of tolerance. So between the two dotted lines is our kind of window of tolerance. If you imagine your sympathetic and parasympathetic nervous system, when you get excited, you have sympathetic arousal, and you're kind of ready for action. And the opposite would be your kind of parasympathetic, kind of slowing right down, things, what we might call arrest and digest. And we oscillate during the day between kind of being relatively aroused and relatively sort of slowed down or shut down. And the impact of trauma is that you oscillate violently between beyond, extreme sympathetic arousal and being completely shut down. And the reason this happens is because we've evolved to have a nervous system that protects us. So the fight or flight response is to run away or to defend ourselves. And as a child who's kind of growing up in a frightening environment, who can't run away and can't escape, they hold this sympathetic fight or flight inside and they can't discharge it. So it becomes, there's no one to talk to about it. There's no way of escaping. So it becomes internalized. And the other way that we kind of protect ourselves, or our nervous systems protect ourselves, is to shut right down and to switch off and become numb or dissociated from the world. And these, during a dangerous time or during traumatic experiences, these are life-saving protective reflexes. The problem is when they continue to operate when you're no longer in that situation. And so what you experience is, as in the slide, a mixture of physiological, psychological, and behavioral kind of effects that happen. So go on, over to you, Kate.
Sure. So I think a really interesting way of understanding this, and someone in the house said this the other day, was when a traumatic event happens, it's like a veil immediately covered their eyes, and this veil was the traumatic event. And no matter what they did next, they would always be seeing life through that veil. They would be seeing life through the knowledge that terrible things are capable of happening, and that bad thing is out there somewhere and it could happen to me again. And I think this is a really interesting way of viewing the trauma world, because independent of my mind, my body is trying to prevent anything like that from happening again. And fight or flight and hyperarousal and hypoarousal was something that has dictated my life since I was 15. And it was almost like I was always preparing for something to happen. And it came through for me in anxiety. It was like I was being held hostage by fear. And it's a fear of something that you can't see, but are constantly anticipating. And I was always predicting the worst possible outcome, because the worst possible outcome has happened before. And if I see the danger everywhere, I'm not going to get caught out. And this used to be constant, this intrusive tsunami of physical effects. And that was totally debilitating, because my heart felt that it was beating out of my chest. I'd be paranoid that everyone was looking at me and I would shake. And this was nearly always accompanied by my head bombarding me with comments about how embarrassing and bad I was. And this prevented me from going to the supermarket, from meeting up with friends, from going to school. And when I was really bad, it even stopped me from going to the fridge. And when none of that worked, when going outside was just scary, I would then shut down, because it was like, if I can't function like that, I can't function at all. And that's kind of how these things showed for me. And it's really scary, because it's like nothing I do, my body feels like it's fighting against me. So you just kind of give up.
And Kate, did you also sort of suffer the opposite, the kind of just utter exhaustion and sort of being shut down or dissociated or cut off or completely numb?
Absolutely. It's like the veil, it's like a fog that just covers, and it's like, I'm not present, I'm with you, but I'm just not here. And again, it's something you really can't control, and it's so frustrating when it happens, because it's not like you can just snap out of it, and you can get triggered by something so small, and it's it's like you're just not present in that moment, you're just not there. And it sometimes you don't even realize you're doing it till after, and you're like, what happened for that last 2 hours, where was I? And it makes interactions really hard because people can see it. um, so yeah, it's another really debilitating thing, and it can happen at any point quite quickly,
Yeah,
which is the other thing.
yeah, it can be very sudden. And so with all of this kind of going on, I like to kind of think that sometimes the problems that we're seeing in diagnosing the anxiety, the panic, the OCD, the obsessive compulsive behavior, the emotional lability, and then some of the physical problems, maybe irritable bowel syndrome, bladder problems, including incontinence, chronic pain, numbness, unexplained seizures, and so on. We see these as problems, but sometimes these are kind of protective reflexes. And then there are kind of behaviors and things that people do to try and deal with the symptoms. And this is a picture of a hand that I use to kind of explain or think about what the trauma world is, or what it does to you. And on the thumb, it's got the fight or flight, which we just talked about, and then the index finger would be shut down, a sense of shame that it's my fault and I'm to blame, the dissociative symptoms, and then the kind of coping. And then kind of it's the coping stuff that we often see that gets people into trouble or into care. And for you, Kate, that was kind of using drugs and alcohol. And how did that help you cope with the symptoms you were getting?
Yeah, I think there's two things that I want to say about this hand. The first thing is that toxic shame can be kind of confirmed when you're not believed. When you're saying, I'm feeling this, and someone else is being like, well, I'm not entirely sure that's right, or you're not believed, or you're not seen, and you're not heard. And so you start to distrust yourself, and it really can feed into that toxic shame. And the coping for me was, I had undiagnosed ADHD, and I was always frantically struggling to get through the day and to self-medicate, to chill down my head, and in some way to control the powerlessness that I felt, not only about what was happening internally, but also in my environment. And my coping strategy wasn't always drugs, that it was an eating disorder, sleeping, TV, Candy Crush. And when I finally found drugs, I felt that I could relax. I felt that I could feel safe. I wasn't completely dominated by life, and I could allow bad things to happen without being present. And the way that I see addictive behavior is now as a mechanism to slot into normal life. And the scariest moment for anyone with these behaviors, whether that be self-harm or drugs or eating or any of them, is the moment that it stops working. And I was trying to self-medicate, which was something that I was always told was biology. And the other stuff that was happening was never dealt with. So I often remained the same.
Yeah, thanks. I mean, we were saying when we talked about this yesterday, I was saying that in our practice, we've run services for patients with opiate addiction for about 35 years, and at one time had nearly 100 patients who were on substitution therapy, and every single one of them had a really significant background of trauma. But it was never kind of described in that way. It was always the addiction clinic, and the problem was always the addiction. And there was, for a long time, I think there was very little, or certainly not enough attention on what purpose was the addiction serving, what problem were these people trying to solve by using these drugs. And it's such a simple, profound, but kind of important change in ways of thinking, and then you just feel differently about your patients, and you feel less frustrated, and you feel more compassionate and more kind of curious, and that makes you more helpful and more resilient as a doctor. So one of the lovely things about this way of thinking, for me especially, is that it's good for patients, and it's good for the people who are trying to look after them. You both come off better off, and there aren't that many things in healthcare where you can say that.
Mm.
The next slide. So of course we're going to say, so what do we do about this, and what can we do about this? What helps? Again, another hand, it's just useful because there's always one that you can look at. And the thumb has social security on it, and that wraps around everything else. If you make a fist, social security wraps around human relationships, what you put in your body, what you do with your body, and what you do with the stuff in your head. But it's sort of the most important thing, and Amy's place gives you that, like nothing else has before. Is that right, Kate?
Yeah, absolutely. And that's why, just to like visually show you that social security is literally underpins everything, because I would get my dose increased and I'd be right back into the place where bad things were happening. And it was so debilitating for me, because it was like nothing else in my life was changing. And as soon as I got to a safe space where people were listening to me, where people on a daily basis were like, how are you doing? Even one conversation would make me feel held. And that's why I think that the trauma world is so complex, therefore the healing world is so complex. And if the medical world put more time into realizing that there's no quick fix for trauma, there would be a lot more patience. And I think your patients feel that patience, and it's a slow process, but also safety can come at any moment. And I think we have had a lot of questions in previous conferences where people say, we've only got 20 minutes, it's hardly any time to, dive into their trauma and ask what happened to them. But what I think is really important to understand is that safety and kindness can be communicated in a few minutes. And I think I was speaking to Dr. Tomlinson yesterday about this one time when I was in the Lawson practice and I was being constantly dismissed. I was really emotional, and I was told to sit down, go to the pharmacy, come back to the GP surgery, and no one was listening to me. And I was in a lot of pain. And Dr. Tomlinson brought me into his room. He moved away from his computer and he said, "What's going on?" And that gave me an opportunity to be like, there is someone in front of me who is listening to me and actually cares about why I'm crying, why this is important to me. And I think just one other thing that I really want to communicate with you today is that all of these things you can't necessarily see, but the patient in front of you really feels them and experiences them. And it's so scary and frustrating when your body is responding to something that isn't there. And the people that can't see how you're feeling just say you're not trying. And trauma thrives in secret and is sustained by being unseen. And the importance of trauma-informed care for me says, I may not see it and I may not understand what I'm seeing, but I see you and I see how this is affecting you. And that must be really hard. I hear you. It's little things like that that can create that social security, that can create safety, even in 5 minutes.
Yeah, thanks so much. I think from my experience, one of the things that's changed is that I've noticed is that doctors, myself included, when you're sat with somebody who's experienced trauma and they're hypervigilant, as you described before, or very anxious or highly aroused, that you start to feel the same stuff, irrespective of what kind of conversation you're having. And so the experience of the professional is that sense of unease and anxiety and feeling like you want to kind of flee or escape the situation. So your own kind of traumatic physiology is triggered by that. And one thing I've learned to do personally is to kind of be really attuned to that and think, okay, like if I'm getting these feelings, something's going on, and there's something going on in this room that isn't being spoken about, but that I'm aware of. And then you have to be able to kind of sit with that. And I think often the experience of people, especially when you're feeling quite hypervigilant, is that of rejection. It feels like the doctor you've come to see actually is trying to get rid of you, or would rather not be there, or is looking for some kind of get out, whether it's a prescription or a referral, or why didn't you I just send you somewhere else, instead of being able to kind of sit with the discomfort in the room and say, as you said, like, what's going on, in a way that's, you know, really sincere.
Yeah. And really quickly, I just want to say that even though it's 20 minutes, it might be the only place that this person gets to be heard in their life. They might be dismissed everywhere they go, but for actually someone to look at them and actually hear what's going on for them is so impactful, because it doesn't feed into the toxic shame, and it says what you're feeling is valid and you are helpable. Because someone that is being dismissed starts to think that they're being melodramatic. And that's also why conditions can worsen, because they start to believe that it's nothing, because everyone has told them that what they're feeling isn't worth anything. So yeah, I think it's just really important for it to be a human on human interaction, rather than a doctor and a patient, and a doctor who's stressed and has had a long day, which I appreciate is the truth, but we can feel that. Yeah,
and the experience of trauma makes you extra sort of sensitive to picking up on those cues, doesn't it?
Yeah.
The I think maybe just actually often, Kate, our interactions, you know, our clinical interactions when you come in aren't 20 minutes. I mean, maybe it feels like 20 minutes, but I've looked through to check, and it's normally nearer 10 minutes. So it's amazing what you can do in such a short time. I sometimes think of general practice as ultra brief and ultra long. So brief encounters over a long period of time. The final slide sort of says, I think we need a compassion that stands in awe of the trauma that people carry, rather than standing in judgment at the way that they carry it. We've deliberately finished a few minutes early, just so that we can respond to any kind of questions or comments that anybody has. We normally have a lot longer to talk on this subject, so it's a short one today. But if there are any comments or questions for either of us, it would be lovely if you want to ask away.
Jonathan, there are some comments and questions in the chat box that I am actually monitoring. Hi everybody, it's Shulek English from NAL Training Hub. Thank you both for your great insight into trauma-informed care as well. It is amazing. So we got one comment from Rini, actually, saying, thank you, Kathleen, for joining us, sharing your story and honesty. Really appreciate hearing the patient voice. We don't hear it enough in these forums. We got another comment from Louise. I agree, it's really helpful to reframe behaviors that people described as challenging as survival strategies. There is a question from Camille. What about people who are not ready to see that their behaviors and emotions are related to trauma? They ironically feel dismissed by professionals going down what they see as a psychological route. They have to feel ready to hear the message and begin the extensive work it takes. And we have a couple more, I think, from Dibesh. I think too often in medicine, we ask if people are smoking or drinking or using illicit substances, but very rarely we ask why. And then another comment, this is something I hear so often from Gay. This is something I hear so often. I hear so many patients who feel unheard, and it manifests as anger, frustration, shouting at professionals. They are immediately dismissed. Me taking the time to listen gives them a glimmer that someone is listening and cares. Kindness and compassion is really important. Couple more old comments are coming in at the moment, but did you wanted to answer maybe that question about what if people are not ready?
I'm going to say a few things and then Dr. Tomlinson, you can go in. But what I will say is that they may not be ready because they've never been given that space. And I think you can't force it. If they're not ready, all you can do is be kind. And you can have this consistency of when they come in, they see you. So they know that after a while, the rapport builds up. And if stuff does come up, you have given them the impression that it is safe. And so when they get to the point where they're like, I can't do this anymore, which people often get to, that's when you can come in and that's when you can start discussing the options. But all you can do is open up that safe space with kindness and compassion, and you shouldn't force it. I think that, but I don't know what you think.
I completely agree. One of the problems I had when I first got into this subject was pushing too hard and trying to say to people, but like, look at what's happened. No, doesn't it now make sense? And it didn't go down very well, actually. I would totally agree with you, Kate, that it will come out if patients feel safe and they trust you. And if you're really struggling, then safety and trust is what you need to work on, not trying to explain trauma to patients. So I don't think trauma-splaining is particularly useful unless it's specifically kind of asked for and it's part of a collaborative kind of exploration about kind of making sense of stuff. And one of a previous patient I taught this with said, like, trauma is a very, very difficult pill to swallow, because it would be so much nicer if you just had something simple for which there was a pill that was going to fix it. You know, that's so much easier than thinking, you mean all the shit that I've been through in my life so far is responsible for the way I feel and for what's going on. Like, that's a really, really big thing to take on, which is why trust and safety and collaboration is so important.
Mm.
Bernice, was there anything else? Do we have time for one more?
Just other kind of comments coming in. It is just a lot of appreciation of your insight and sharing your experience in terms of the comments. I think I'm going to hand over to Lily, given the time is now 10:15, if that's okay.
Kate, thank you so much. That was wonderful. Thank you.
Thank you for having me, guys.
Thanks a lot.
Bye.